So good morning, good afternoon, or good evening, based on where you are joining us from today, and welcome to our webinar. My name is Laura. I am the Executive Manager of the World Stroke Academy, which is the educational platform of the World Stroke Organization that provides stroke education to health professionals worldwide. Now, it is with great pleasure that we are hosting this educational activity today with over 700 of you that have registered to learn more about Factor 11, 11A inhibitors for stroke prevention, evolving evidence and clinical relevance, a webinar that is supported by an unrestricted educational grant from Bayer, which we very much thank for their support. As per usual, before starting, a quick look at our housekeeping rules. We welcome any questions you might have throughout the webinar, but we kindly ask you to use the Q&A box for those in your Zoom control panel. This way, our chair can pick the questions and address them during the Q&A discussion at the end of the webinar. Also, a reminder that this webinar is recorded, and the recording link will be sent out to all of you via email shortly after the webinar, and it will also be uploaded on the World Stroke Academy site, so you can easily access it and rewatch on demand. And lastly, we kindly invite you to fill in the evaluation survey. This is very important for us to get your feedback on these webinars, but also for you to be able to claim your certificate of attendance. Now, without further ado, I will introduce our chair, Professor Valeria Caso. She is the Chief of Neurology at the Stroke Unit at the Ospedale di Saronno in Lombardia, Italy, as well as our World Stroke Organization Treasurer. Valeria, the floor is all yours.
Thank you, Laura. Thank you all for coming and joining and seeing, as Laura said already, there's a great interest in this topic. And I think we are quite lucky. Every time there's something new in our research and something new, I don't want to say on the market, but something that will change maybe our behavior in stroke treatment, it is always an exciting time. So I'm here with three distinguished speakers. I will introduce them one by one. And we will start with Professor John Eikelboom, who is Professor of Medicine at the McMaster University in Canada. And John will clearly, finally, let us understand the mechanism of the coagulation cascade, because he's the only one that I really understand when he's talking about this raffinate and very difficult mechanism. So, John, the floor is yours.
Well, thank you very much, Valeria, and good morning, good afternoon, good evening, everyone. Truly a pleasure. I'm delighted to be here with you today, and let me ensure that my slides are working, which I think they are. My task is to review with you how these drugs work, and Valeria has suggested that I will be able to do so clearly. I have to confess that our understanding of mechanism of action is constantly informed by the results of trials. But we do have a good framework for explaining these drugs. Now, let me start very briefly by reminding you of the status of anticoagulation in 2025. And we have a rich heritage of anticoagulants, starting, of course, with those discovered by serendipity, unfractionated heparin and warfarin, those that first represented the designer drug, the designer anticoagulant, and then direct oral anticoagulants that have revolutionized practice. However, our existing agents have very important limitations. The first and the most important is bleeding risk. And I don't need to remind any clinician of the enormous impact that concerns about bleeding and bleeding events themselves have on patients and on clinical care. There is tremendous under-treatment because of bleeding. We also have areas where existing agents are limited and in their efficacy, That means that we continue to use a drug like warfarin, which very effective, but much more difficult to use and even more bleeding. And then there are areas where the existing agents are contraindicated. So a compelling rationale for a new class of anticoagulants. What would we like to see in this new class of anticoagulants? Well, perhaps in order of decreasing importance, we'd like better safety, we'd like better efficacy, particularly where DOACs are currently relatively ineffective. We don't want to lose the practical advantages of DOACs. We'd like the new drug to be cleared through primarily non-renal mechanisms, and we'd like to eliminate drug-drug interactions if possible. Now, what's remarkable about factor XI inhibitors is that they offer a potential to address, to some extent at least, each of these desirable characteristics. So here we have the next generation, potentially the next generation of anticoagulant, the factor XI inhibitors, which include abelacimab, asundexian, and milvexian as the best known agents. But also additional agents. Well, what's the rationale for tackling factor XI? Why develop drugs that target factor XI? We have 3 lines of evidence to suggest that factor XI inhibitors will have less bleeding than existing agents and still be efficacious. The first comes from epidemiology. Inherited factor XI deficiency is associated with a lower risk of bleeding than folks who do not have factor XI deficiency, and people with inherited deficiency have less stroke and less venous thromboembolism. The second line of evidence is from animal experiments where the use of a factor XI inhibitor reduces thrombosis, but there is a low risk of bleeding. And then the third line of evidence is from the early clinical studies. Well, you may say, well and good, but what is the biological and what is the pharmacological basis for expecting prevention of thrombosis without bleeding? We've heard that story before. Convince me that it's actually going to be true with this new class of factor XI inhibitor. I'll show you conceptually at first using this slide, and then I'll take you through some detailed slides to try to spell it out. But here we have on the left-hand side of the slide a model of extravascular injury, such as occurs after trauma. After trauma, there is a large thrombin burst, a very large thrombin burst, which by itself is sufficient for hemostatic plug formation. On the right-hand side of the slide, we contrast extravascular injury with intravascular injury, an intravascular event such as plaque rupture. This leads to a relatively modest thrombin burst. This thrombin needs to be amplified, and that amplification is dependent on factor XI. It requires this amplification pathway to produce enough thrombin to form a pathologic thrombus. Well, all thrombus is pathologic, but you know what I mean, to occlude the blood vessel, resulting in the stroke, the myocardial infarction, or the episode of peripheral ischemia. Let's take a step back and look at coagulation. On this slide, we have on the left the contact pathway, which is activated by mechanical valves or by extracorporeal circuits. And on the right side of the slide, we have the tissue factor pathway, which is activated following extravascular injuries such as trauma or intravascular injury such as plaque rupture. Both pathways converge on the factor 10, a common pathway leading to thrombin generation, leading to fibrin formation and platelet activation, and accounting for both thrombosis and hemostasis. So let's take separately different ways to activate coagulation. Here we have the extravascular trauma model, where there is external injury to the blood vessel. Tissue factor 7A complex leads to factor 10 activation, to thrombin generation and hemostasis. You will notice that the hemostasis in this pathway is unrelated to factor 11. Factor 11 is not involved. Now we have the same model with extravascular vessel injury. If we give heparin or warfarin or a direct oral anticoagulant, we block factor 10, we prevent hemostasis, and we prevent thrombosis. If we give factor 11, because the factor 11, if we give factor 11 inhibition, because factor 11 is not involved in this hemostatic pathway, hemostasis proceeds unaffected. Now, let's look at intravascular vessel disruption. This is plaque rupture. There is a large burst of thrombin induced by a modest burst of thrombin induced by the tissue factor 7A complex. The thrombin that is formed feeds back through factor 11 to generate more thrombin to create thrombus. If we give heparin or warfarin or a direct oral anticoagulant, we block thrombosis, but we also impair hemostasis. If we give a drug that targets factor 11, factor 11 is key here in thrombosis. We will block thrombosis, but we leave hemostasis relatively unaffected. And that explains the same slide here. On the left, extravascular injury, large thrombin burst, hemostasis. On the right, intravascular injury depends on factor 11 inhibition, on factor 11 activation and amplification. Factor 11 inhibition does impede this pathway, but it does not impede the extravascular tissue injury pathway. And that is the theoretical basis for targeting factor 11 to uncouple hemostasis from thrombosis. There is one more thing to be said about factor 11 inhibition. Not only does it uncouple thrombosis from hemostasis, but by specifically targeting the contact pathway, the potential exists for factor 11 inhibition to be efficacious in people with mechanical valves and extracorporeal circuits. This has to date not been tested, but it is an additional promising role for factor 11 inhibition. There are several classes of factor 11 inhibitors under clinical evaluation. You're going to hear a lot more about this, and I won't go into any detail except to say this level of development reflects the excitement in the potential for factor 11 inhibitors to change practice. Where to from here? Well, again, you'll hear a lot more about this during the rest of this seminar. We're looking to see how do these drugs work versus control in people not currently requiring anticoagulants, such as stroke. How do these drugs work versus control in people who currently can't be anticoagulated? How do these drugs work versus the current anticoagulants? How do they work in people with devices or valves? And how do we manage them for perioperative care? And with that, I leave you one resource, a lovely recent review, and I thank you for your attention.
Thank you. Thank you. As always, very informative and throughout revision of the mechanism of factor 11 and thrombosis mechanism. Now we will move to a clinical part, as already introduced by you, John. Now it's my great pleasure to welcome on stage Professor Gisele Sampaio Silva, Professor in Neurology at the Federal University of São Paulo and head of the Neurology Clinic Research at the Albert Einstein Hospital in Brazil. And Gisele will speak about the clinical implications in stroke prevention.
Thank you so much, Valeria. It's such a great pleasure to be here. I'm going to share my screen. And of course, the previous lecture will help me a lot to go ahead and discuss a little bit the potential impact of factor 11 inhibition on current antithrombotic treatment strategies for stroke prevention. Can you see my screen well, Valeria? Yes? Okay. So those are my disclosures and the learning objectives of this webinar. So we're going to discuss a little bit the gap that we still have in stroke prevention. And later on, Dr. Ashkan Shoamanesh is going to talk to us a little bit about the very exciting results from the new trials and what we can expect from the next years. So it's very clear that we still have a problem when we talk about stroke recurrence after minor stroke and TIA. So data from the TIA registered, led by Pierre Marenko, showed that in the first year, so stroke recurrence can go up to 6%. So even though we are doing our best and treating our patients with the antithrombotic options that we have nowadays. And this is even worse. So this percentage can go up to 13% if you go to the 5 years follow-up and up to 20% when we go to the 10-year follow-up. So that means that 1 in every 5 patients that we treat after stroke might have a recurrent stroke if we're still doing the best thing and giving our patients everything that we know do work. And of course, when we discuss stroke prevention, we base our treatments in antithrombotic therapies, antiplatelets, or anticoagulants. Although we should be looking into all other, risks for recurrence and all other risk factors, but basically what we've been giving to our patients for more than 20 years, we've been like blocking platelets with aspirin, so blocking the thromboxane A2 generation, or either we are blocking the P2Y12 with the new antiplatelet drugs like clopidogrel, clopidogrel, and prasugrel. And we've been learning a lot with cardiologists, but of course, as it was very well pointed by Dr. Eikelboom, the brain is much more sensitive to bleeding. So bleeding is always a problem, and we know that our patients with stroke are always the ones who bleed more when they are treated with antithrombotics. And of course, there was a very huge revolution on antithrombotic therapy with the trials that evaluated factor 10A inhibitors using rivaroxaban, apixaban, and edoxaban. And that changed a lot in the way we manage patients with atrial fibrillation. But the bad news is that, factor 10A inhibition can also lead to bleeding. So they were tested in patients who did not have atrial fibrillation. And although they can prevent thrombosis, they are not ideal because the balancing between bleeding and preventing ischemic events, it's not very well established for patients who do not have atrial fibrillation. So what we've been doing, what are the trials that actually evaluated antiplatelets in patients with ischemic stroke? So we started with the MATCH trial. So we've been using dual antiplatelet therapies for a while. So a trial that included more than 7,000 patients, follow up those patients for 18 months. And used clopidogrel plus aspirin versus clopidogrel plus placebo. It was a long-term based trial, so patients were using dual antiplatelet therapies for a while, and match was very important because we've learned that dual antiplatelet therapy also makes our patients bleed. So when we compare it to anticoagulation, the rates are actually similar to treating patients with warfarin, that was the drug that was used for anticoagulation at that time. So after we learned this, we went to the trials using clopidogrel and aspirin, but that actually restricted the timing to less timing. So with chance and point, so we included patients with minor strokes or TIAs. So the patients were followed for around 3 months. And we were able to see that actually using dual antiplatelet therapy is effective for preventing ischemic stroke in such patients, and we should be using it for a shorter period of time. Later on, so just learning from the cardiology, we try to use ticagrelor and aspirin with the TALIS trial. We've learned that, comparing ticagrelor and aspirin versus aspirin is more effective in preventing ischemic strokes, but also patients do bleed a little more. And then we had the evaluation of the CHANCE-2 trial, bringing a more personalized therapy for patients who have genetic mutations that prevent clopidogrel, that is a prodrug, to become a real drug, and showing that using ticagrelor in these patients might be of benefit. And we also learned by the chance and the point trials that we probably should not be using dual antiplatelet therapies for a longer period of time. The sweet spot in between, the effect of dual antiplatelet therapy in preventing recurrent events and not causing major hemorrhage is around 14 days, into between 14 and 21 days. And this became practice, and that's what we've been doing, and that's what it's in our guidelines. So we've been using very short-term dual antiplatelet therapies in patients with minor stroke or TIAs, and this has been our practice. We know that recurrent stroke, it's a real problem. So a recent survey actually asked patients what is the biggest fear that they have after they had a stroke. And it was very impressive because the most frequent answer was not of disability, was not of dying, was of having another stroke. We do know that recurrent stroke causes greater mortality and has a poor prognosis, so has a negative impact, of course, on functional independence as well, a very negative impact on emotional and psychological well-being. So that's why we are here to try to prevent, new strokes and try to evaluate new therapies that could prevent our patients from recurrence. In Brazil, we have a big database from the northeast part of the country that was done like 10 years ago, that I have the privilege to be the principal investigator, that unfortunately we shown that almost 30% of the patients who were admitted in the city of Fortaleza with a stroke had a previous stroke. So we just lost the opportunity to prevent new events. And we have to do this not only by looking at antithrombotics, but also looking at antihypertensive therapy, glycemic control, that's something very important, using dual antiplatelet therapy for the amount of time that does not increase the bleeding risk of our patients. Always remembering that antithrombotic is important, but we should be checking the lipid levels of our patients, and we have data for patients with atherosclerotic stroke to put in LDL levels less than 70, maybe even lower with the new trials that are ongoing. And of course, to look into Life Essentials aid from the American Heart Association, asking our patients to go ahead and have exercise, have a more healthy life. This is also, of course, very, very important in a long-term basis. And then our idea initially was maybe that using direct anticoagulants would be a way to prevent recurrent stroke in patients with ESUS, because we thought that, many events that does occur in patients with ESUS are due to not diagnosed as atrial fibrillation. So we had the trials that actually checked using DOACs in patients with ESUS. So very well done trials with large sample size, but unfortunately, no significant results. And of course, after we evaluated the trial results, maybe being a little bit more critical, we could understand that most of such patients that have ESUS, they do not have atrial fibrillation. So many of those can have atherosclerotic disease that is not stenotic atherosclerotic disease. So maybe thinking in another way, to block the coagulation cascade in a safer way would be some way to go in patients with ESUS that unfortunately we've been treating with aspirin since then. So we've just heard about the idea of, the sweet spot of being able to prevent hemostasis, that it's actually very important for us in the day-to-day basis, and avoiding the pathological propagation of the thrombus that's actually able when we block factor 11A. So this was learned, because we know how the coagulation cascade does work. We also know that there is data showing that patients who have hemophilia C, so who have the factor 11 deficiency, they do not bleed like patients with hemophilia A or B. So they don't need transfusions, but they also don't have ischemic events in their lifetime. So this is a very important learning that we had from a disease that learned us that we can maybe evaluate mechanisms of creating new drugs by understanding how some diseases do work. So we know that there is a relationship in between the levels of factor 11 and the risk of thrombotic events. And we do know that when those patients with very low factor 11 levels, they do not bleed. So making us think that blocking this pathway might be safe and actually might prevent ischemic events in patients with ischemic stroke and other ischemic events as well. And also, we had the opportunity to learn with the COMPASS trial. So with Dr. Ashkan Shoamanesh was very involved with it, and also Mike Sharman, who evaluated this dual blockade of platelets and anticoagulation by using rivaroxaban in a very low dose, 2.5 milligrams twice a day plus aspirin, and comparing in patients with high cardiovascular risk. So we are not talking about exactly of patients with stroke, but doing this dual blockage, the COMPASS trial showed that the primary event that was most prevented in such trial was stroke. So this was very striking, and we could see that those patients also didn't have an increase in intracranial bleeding when using this combination of rivaroxaban 2.5 BID and aspirin when compared to aspirin alone. Of course, in the overall trial, we had around 291 strokes overall, so it's not a definitive trial, but it was very striking. So the trial was terminated early, probably because of the capacity of this combination of rivaroxaban and aspirin to prevent stroke. So when we compare to the other composite outcomes, so you can see here the subtypes of stroke of such patients in the COMPASS trial. So in the effect of the combination of rivaroxaban 2.5 milligrams a day and aspirin, preventing cardioembolic strokes and preventing embolic stroke of undetermined cause in the COMPASS trial. So, of course, this led to what Dr. Ashkan Shoamanesh is going to discuss with us, to the design of the phase 2 trials. We had the Pacific stroke with asundexian, and you have the axiomatic trial with milvexian. Both were trials that were done all over the world. So I had the privilege of being the principal investigator of the axiomatic trial here in Brazil, with a lot of representation from different countries and different ethnicities. So this is very important when we are developing a drug. And we do know that Dr. Shoamanesh is going to talk a little bit about the specificities of those trials, but we know that when we go to the to the recurrent stroke or TIA recurrence. So we had in the axiomatic trial those relationship of the prevention of clinical events. So the trial was not positive for covert events, but it was in a dose response positive for clinical events. And very, very striking, it was safe. So those trials were using drugs such as sundexian and milvexian upon the use of dual antiplatelet trial. So you can see here the bleeding event. So this is really, really exciting. So we are giving a therapy upon dual antiplatelets, which is the current standard of care for our patients, and our patients are not bleeding. So just, making us understand that probably this mechanism of action of uncoupling hemostasis and thrombosis really, really can be replicated in the real world and in the clinical trial. This is the result of the axiomatic trial. So the trial was also positive for symptomatic stroke, not for covert stroke, but most importantly, major bleeding at 90 days was not increased. So really, really excited to think that we have a class of drugs that can prevent ischemic events and do not make our patients bleed. So very recently, we had the presentation from the baseline data of the Oceanic Stroke Trial by Mike Sharman at the World Stroke Conference in Barcelona. So it was a huge trial with more than 12,000 patients enrolled. Unfortunately, Valeria, we still had only 33% of female patients. So we are working on trying to understand that. And you are going to have the results presented in the International Stroke Conference this year. But we had a publication from Bayer, saying that we met the primary efficacy for safety and just for efficacy and safety for the Oceanic Stroke trial. So we're really excited to be part of this trial and to bring to the stroke community, new hope in preventing stroke overall. So just as takeaway message, we have a large unmet need for secondary stroke prevention. And the inhibition of factor 11A represents a very promising target due to its potential of uncoupling hemostasis and pathologic thrombus formation. Dr. Shoamanesh is going to talk to us a little bit about the results of the Pacific and axiomatic stroke trial, and Oceanic is going to be presented in 2006, and you're really excited about this. So these are my references. We have some additional resources, some interviews with Dr. Mike Sharman and Dr. Shoamanesh after the World Stroke Conference. And those are my contacts. I'm really excited to be here with this wonderful panels of experts today. Thank you so much, Valeria.
Thank you. Thank you, Gisele. So it's now my great pleasure to introduce Professor Ashkan Shoamanesh, Associate Professor of Medicine and Stroke Neurologist at the McMaster University, Director of the Hemorrhagic Stroke Research Program at the PHRI in Canada. So you will now give us a very important update about what we know already and where we want to go. Thank you, Ashkan.
Oh, thanks very much, Valeria, and hello, everyone. Thank you so much for joining us wherever you may be in the world. About something that's quite exciting, right? As you heard from Gisele, we now know that the top-line results of oceanic stroke are positive. I'll briefly share what that exactly means, but also give you a more detail into what led us here as far as the clinical trials go. My most relevant disclosure is that I have worked with Bayer with the development of asundexian from the phase 2 study and now the phase 3 oceanic stroke trial. So our objectives are to, one, review clinical trial data on factor 11, 11A inhibitors with a focus on secondary stroke prevention, summarize the design of ongoing randomized trials, and then lastly, highlight baseline demographics in a bit more detail, as well as recently announced top-line results of the oceanic stroke study. So as you can see, and John alluded to this, there are several molecules that are currently being tested for targeting either factor 11 or 11A or factor 11 and 11A together. And those are antisense oligonucleotides, monoclonal antibodies, as well as the direct small molecule inhibitors of factor 11A, which are the ones being tested for secondary stroke prevention. But as you can see, there's a large wealth of trials that are ongoing targeting different disease states. And historically of interest for us, this is the first time that in phase 2, we've actually had dose-finding trials of an anticoagulant prior to going into phase 3, that historically we've often used the doses that were proven in either VTE or AFib prior to testing them in stroke prevention. But this is where really, and the proof will be in the pudding, that we now, as we've indicated, have a positive trial where we've tested the appropriate doses in phase 2 and then moved on to phase 3, which I think will be a recipe for success moving forward as well. But other disease targets have been AFib, ACS, and AMI. And similar to the history of direct oral anticoagulant development, the very initial studies were looking at the prevention of venous thromboembolism in the context of total knee arthroplasty. And in phase 3, really, we're looking at VTE prevention, or the community is looking at VTE prevention in patients that have cancer-associated thrombosis. And the couple of trials that have read out now in phase 3 is one, the Oceanic AF study that was co-led by our chairwoman, Dr. Caso. And this was stopped at interim analysis due to futility, unfortunately. This was a trial testing asundexian compared to a standard dosing of apixaban, so an active, very effective comparator for AFib. And this study, although it was did not show a superiority for efficacy and actually was inferior for efficacy, what was quite prominent and pronounced was the significant reductions in bleeding compared to apixaban with asundexian 50 milligrams daily, which in terms of indirect comparisons in a similar population where apixaban had similar bleeding to aspirin, would lead us to believe that perhaps these drugs may be even safer in terms of their bleeding profile compared to aspirin, although of course that's a stretch due to indirect comparisons, which can be quite inaccurate. Similarly, Librexia ACS was also stopped at interim analysis due to futility. Most recently, this was testing a milvexian against placebo on top of antiplatelet therapy in patients with coronary artery disease who have had a recent myocardial event, and the details of the results have yet to be announced publicly. Now, the proof really of concept about the potential to have superior efficacy with reduced bleeding risk comes from the milvexian TKR trial that was led by one of our thrombosis experts, Jeff Weitz at McMaster University. And here, escalating doses of milvexian, direct factor 11A inhibitor, factor 11A rather, excuse me, led to improved prevention of VTE with similar rates of low bleeding compared to enoxaparin. And a large clinical program that was led with Bayer in phase 2 was the Pacific program, where 3 disease states were targeted. That was AF, AMI, and our Pacific stroke trial, which I'll focus on. And in this study, patients with non-cardiovascular ischemic stroke or high risk, or with it presenting within 48 hours of symptom onset, were randomized 1:1:1:1 to either asundexian 50, 20, or 10 milligrams daily or placebo on top of background antiplatelet therapy. And these patients were randomized up to 48 hours and you needed an MRI up to 72 hours post-randomization, as well as an MRI at end of treatment because of the co-primary endpoint, which included covert infarcts and MRI. And in total, 1,808 patients were enrolled in 196 sites in 23 countries. Bottom line for this study was that the primary efficacy endpoint was negative and that there was no dose-dependent reduction in the composite endpoint of ischemic stroke or covert infarcts at 6 months. However, this seemed to have been driven by a complete lack of effect on the covert brain infarct component of this composite, which monopolized the composite endpoint, accounting for 3/4 of all events. And 70% of these events were small subcortical infarcts that we just see often due to small vessel disease, but also they can also be kind of dilated perivascular spaces that are often misdiagnosed or mislabeled as small subcortical infarcts. But when we looked at the clinical component of the primary endpoint, which was ischemic stroke in isolation, there was a suggestion of a 20% reduction with asundexian 50 milligrams daily versus placebo. Next, we did this experiment or exploratory outcome, because we had used the composite endpoint, including covert brain infarcts, to improve our power in the phase 2 trial, and that did not work out well. Well, we were thinking, well, what other cerebrovascular event that's actually symptomatic and not just an MRI asymptomatic finding can we use to perhaps improve power to see if we see a trend for a dose-dependent effect? And this is where we looked at this exploratory endpoint combining ischemic stroke or TIA, where there actually, this composite endpoint was reduced from 8.3% in placebo versus 5.4% with asundexian 50 milligrams daily, with a dose-dependent suggested effect, with the highest dose having a 36% risk reduction in this exploratory endpoint. And these benefits were seen without any excess in clinically relevant or major bleeding defined by the ISTH. This was a primary analysis looking at all the events in pooled doses of asundexian arms versus placebo. There was also no excess risk of all bleeding. And importantly, for stroke neurologists, when we're introducing an anticoagulant on top of antiplatelet therapy and comparing it against placebo, was whether there's any bleeding into that recent infarct or hemorrhagic transformation of the qualifying infarct. And we did not see any evidence of that either when looking at hemorrhagic infarction or parenchymal hematoma formation. So this was quite reassuring to move on to a phase 3 trial. In parallel, my colleague Mike Sharma was leading the milvexian trial, which was axiomatic SSP, similar design study testing a larger number of doses of milvexian, with key differences in baseline characteristics being that you had to have had some degree of atherosclerotic disease to enter the study, and that just had to be any athero visible on vascular imaging. High-risk TIAs were also eligible if they had an ABCD squared score of 6 or greater. And similarly here, with the composite endpoint of ischemic stroke or covert brain infarction on MRI was negative, but again, that was the covert brain infarction component that was not responsive, whereas when you looked at ischemic stroke in isolation, there was suggestion of a dose-dependent response, and again, similar signals of safety, with particularly up to doses of 25 milligrams BID, which are now going into phase 3 for this indication. So the 2 phase 3 trials that are now ongoing are one, the oceanic stroke trial. This was actually completed, and this is patients with acute non-cardiomyopathic ischemic stroke or high-risk TIA, and we've enrolled over 12,300 participants, and these patients were randomized to asundexian 50 milligrams daily or placebo, both on top of background antiplatelet therapy. Our primary efficacy outcome was time to first occurrence of ischemic stroke, and our primary safety outcome was time to first occurrence of ISTH major bleeding. Similarly, Librexia stroke trial is ongoing, which is looking at a similar population and testing milvexian versus placebo. The milvexian dose is at 25 milligrams BID dose, both on top of background antiplatelet therapy, and their outcome is also, the primary endpoint is also time to first occurrence of ischemic stroke. Now, I am excited to say that we really had a great network of collaborators in oceanic stroke across over 700 centers in 38 countries on 5 continents, which allowed us to reach our target sample of over 12,300 participants in just over 2 years. And then we've just completed our additional year of follow-up in this event-driven study. And in these patients, we now, the baseline demographics show a very large generalizable population to the patients that we treat in the hospital or in clinic. With a mean age of 68, a third of the population was female, which reflects some of the ongoing difficulties we have in enrolling females in stroke trials, particularly in the context of stroke prevention. 20% had prior history of stroke or TIA, 16% had coronary artery disease, 80% were hypertensive, a third of the population was diabetic, and a quarter was smoking. Large global representation, 40% from Western Europe, 30% from Asia, 15% from Eastern Europe, 13% from North America, and 5% from South America. The baseline event at entry was ischemic stroke in 95% of cases and TIA in 5% of cases. This reflects partly the high the ABCD2 score rather, that patients required to enter the study with TIA with a cutoff of 6 or greater. And really what we're excited about most is this large representation of different stroke subtypes at study entry. 5,000 large artery atherosclerosis. In comparison, for instance, the Sparkle trial, which tested atorvastatin in patients with atherosclerosis, was about 4,900 participants. Stroke of undetermined etiology or cryptogenic strokes, and a large proportion of these will be ESAs, 3,500 patients. As Gisele showed us, the trials of ESAs kind of the respect ESAs was 5,000 patients, Arcadia was 1,000 patients. Small vessel occlusive disease, 25 or 2,600 patients. The SBS3 trial was 3,000 participants. So with such a large study, we actually are going to have excellent power, or at least reasonable power, to look at these different stroke subtypes in isolation to see how they fared. Now, patients with strokes of other determined etiology or cardioembolic strokes were not eligible for the study. However, some of them, the mechanism did not become clear until post-randomization. So we will have some information on how these patients fared as well, but although with very small numbers. And I'll mention in John Eikelboom's COMPASS trial, patients with cryptogenic or stroke events that were due to ESAs or cryptogenic stroke were those that responded most from dual pathway inhibition. So we're also very excited to look at this in subgroup analysis, which will also be presented at the ISC in February of 2026. So the NIH presentation was roughly 3, although we allowed NIHSS up to 15 for eligibility in our study. And at randomization, it was 2, but with a range of 2 to 26. And what we're also will be very interested in looking at in detail is how did patients fare if they received IV thrombolysis prior to study entry. And here you'll see that about a quarter of the population received either IVT or endovascular thrombectomy. 20% received IVT, which is a pretty good proportion of patients with ischemic stroke, some of the comparable to the rates you see in some of the best centers in the world. 3% received EVT only, and then about 4% received both. And then we also stratified randomization according to intended use of dual antiplatelet therapy versus monotherapy. And here, 2/3 of the population, the treating physician was intending to use DAPT, and a third was intending to use monotherapy. As you heard from Gisele, the primary efficacy and safety results were announced in terms of just the top line effect, and we were successful in one, having a reduction in our primary endpoint, which is time to first occurrence of ischemic stroke, without any excess in time to first occurrence of major bleeding, which was a primary safety endpoint. Unfortunately, I'm unable to share the details with you today, but my colleague Mike Sharma will be presenting them at a major podium presentation at the ISC in February of 2026. And we're all very excited to share the details with you in regards to this very new paradigm and a new treatment option for our patients. So to conclude, factor 11 inhibition is an exciting new paradigm for secondary stroke prevention. The phase 2 secondary stroke prevention trial suggested a reduction in ischemic stroke occurrence without an increase in major bleeding, and they were very consistent in their findings. The oceanic stroke top-line results validate, excitingly, our ability to uncouple pathologic thrombus formation from hemostasis with a potential to have far-reaching impacts in the field of cardiovascular disease beyond secondary stroke prevention. And factor 11 inhibition, I'm really excited to say, will soon be a new treatment option addressing a high risk of residual stroke among the approximately 5 million people worldwide who experience a new non-cardiovascular ischemic stroke or high-risk TIA each year. So thank you very much for your attention, and I very much look forward to engaging in the Q&A.
Thank you, Ashkan. Thank you very much. I ask all the speakers now to join and put their camera on. So I think my personal feelings is that it's really exciting. So to have the idea of a new treatment in such difficult disease such as non-cardioembolic stroke, and we know that in 5 years there will be a 20% of recurrence rate. So we have this treatment, but where do you see the pitfalls in implementation? So, for example, we have a very mild population. You said already they were treated by thrombolysis and thrombectomy, so our acute treatment has improved, and probably they had severe stroke at onset. But do you think that people or our colleagues will feel that is something for a milder patient population? So this is a question that I asked also to Gisele and to Ashkan.
I'll maybe just say that it's fair that the kind of mean NIHS here is low, but it's interesting to we tend to overestimate the mean NIHSS in current practice amongst patients with non-cardiovascular ischemic stroke. If you look at for instance, one argument may be that this was an anticoagulant study and physicians may have been more reluctant to initiate or enroll patients that have higher NIHSS. But if you look at the CONVINCE trial that looked at colchicine, which is not an anticoagulant, no risk, their mean NIHSS was also quite low, about 2 or 3. I can't remember exactly. And when you look at registry of this population, the mean NIHSS ranges somewhere between 3 and 5. So it is actually reflective and generalizable to the population of non-cardiovascular ischemic stroke. Now, there are patients that have higher kind of NIHSS, of course, still. And we do have about 20% of cases that had an NIH. I believe the cutoff that we selected was 8 to 15. So we are going to be able to look at that subgroup as well and see how they're fared. So that will be really reassuring in this regard. And then another point I think that you raised is also, well, why should we use new, perhaps expensive anticoagulants in a minor ischemic stroke population? And the assumption there would be that just because their initial ischemic stroke was non-disabling or NIH of 3, and some of those are disabling, but let's say a low NIHSS, that their recurrent event will also be low NIHSS. And actually, there's some interesting data from Thales that Pierre Marenko did a subgroup analysis, not a subgroup analysis, but a secondary analysis, demonstrating that 2/3 of recurrent events in Thales, which was also minor ischemic stroke high-risk TIA population, ended up being disabling strokes based on a cutoff of MRS of 2 or greater. So we're preventing disabling events. And this further kind of emphasizes the unmet need in this population.
Yeah, Ashkan, I completely agree. I think that the subgroup analysis from both trials are going to be important for us to evaluate how those drugs, they do work in strokes that are more severe than the lower NIH stroke scales that we are seeing as a median from both trials. But it was good that we actually included some patients with high NIH stroke scale. And yeah, the recurrence rates are unacceptable right now. Yeah, so we're doing our best, but our patients are still recurring. And I think that the most exciting results of both trials is safety, because we do know there's always a balance. Whenever we anticoagulate our patients or when we increase the antithrombotic activity, we do prevent ischemic events, but on the cost of bleeding. And I think that very strong message, at least up to now, that we have, it's of a lot of safety. Our patients, they are at risk for bleeding. And I think that maybe what happened with the WAC is that we are actually using like a bomb to kill like a small bug. And now we have a drug, that's actually effective, but does not increase the risk of bleeding, and we can use on a long-term basis probably. So that's really, really exciting. And I think that, Valeria, for implementation, still, I don't think that antithrombotics are the magic bullet alone. Yeah, looking for all, that prevention, chain that we have from, preventing treating lipids and treating hypertension. And maybe in the future, we might be able to design trials that use combination therapies and that are going to be, effective overall, except of, focus only on antithrombotics. So it's much more than antithrombotics, I think.
If I could just add one sentence, I mean, what you call a minor stroke is to me a quality of life threatening, mortality threatening, survival threatening event. So if this truly is a drug that reduces recurrent stroke with minimal or no impact on bleeding, I would say, why not if you take out the cost? But that's a future discussion, I guess.
Yeah, absolutely, John. This is an excellent point. There's a question from the audience, and I pass it to you, John. Any idea why factor 11 would work in non-AFib ischemic stroke, but not in patient with, myocardial infarction?
Yeah, that's a wonderful question, and these are always data-driven, retrospectively designed hypotheses. I don't have a compelling hypothesis at the moment. All I can say is that it would be consistent with the epidemiology, but why is this so? I don't know. I'm sure we're going to think of a hypothesis, which is then going to become stronger and stronger until it's disproven. But that's the best I can say at this stage.
Well, one thought I've had looking at initially at the epidemiology before even the clinical trials came out is, well, how does it make sense that this drug would work in, patients that have inherent factor 11 deficiency will have less ischemic stroke and not MI. And one thought is that this is a clot propagation inhibitor, right? It's not a clot initiation inhibitor, as John showed you nicely. That initial thrombin burst occurs, is moderate, but it needs factor 11 to propagate the clot. So if you have an initially small vessel, like a coronary artery, and now you stenose that vessel with a bunch of plaque so that it's only a pinhole before it ruptures or has 50% stenosis essentially from the atherosclerotic disease, you now have a very small lumen. So that initial thrombus before factor 11 even plays a role may be sufficient to cause pathology in a small artery that already has stenosis, pre-existing stenosis. Whereas in a larger artery, where you have, particularly if you have less severe pre-existing stenosis, that's where the clot propagation may be more important to prevent pathology, but that's pure speculation. And I agree with John, we still have a lot to learn here.
Yeah, I agree. There's a question, very interesting question, and how long we discussed regarding DOACs and thrombolysis. Would you give, in case of stroke recurrence, patient who is on factor 11, would you give thrombolysis, not treat thrombolysis? Is there a possibility to dose it? And so this is a question for the panel.
I can maybe take a stab. We don't know. So take everything I say with a word of caution. But there's been an animal study that was done by Bayer where they showed that if you pre-treated but rather animals with asundexian and administered thrombolysis, the bleeding risk was the same as a animal that had not received asundexian. And we know now with kind of at least some of the emerging observational data that's driven out of Switzerland with the Do It initiative that we're now collaborating with for the RCT, is that it seems, at least all the data so far, although observational, that it's safe to give thrombolysis on top of DOACs, or at least there seems to be benefit, although that's yet to be proven. So I would take it the same way as I approach a DOAC patient right now, with even greater sense of reassurance. So it's case by case. If EVT is not an option and the patient has disabling deficits, I would give the thrombolysis myself. But there really isn't a definitive answer at present. The nice thing is that with Bayer support, we have collected all the images of the ischemic strokes, including those that receive thrombolysis during study participation. So we will have some small but informative data regarding outcomes and hemorrhagic transformation rates in patients who receive thrombolysis in the asundexian arm versus the placebo arm during the study conduct.
Excellent. Any other comment from? If not, I pass to the next question. It's about the small vessel disease. Is this a risk that the results of Oceanic can be diluted?
What can I say is hang on to your seats. We'll see the subgroup results. So Mike Sharma, the trial PI, Mike Sharma will be presenting the primary results. Myself as co-PI will be presenting the main subgroup analysis on stroke subtypes, both at the ISC. So those will both be presented in February of 2026. So stay tuned.
Okay, last question. There's a question which is expected? Why didn't it work in oceanic AF? So again, this is something I think it's always important to answer, because this will always be the elephant in the room, and I think this needs to be answered all the time. It is asked.
Well, Valeria, you're a co-PI. Well, with Oceanic. Where you got that?
Valeria,
But I give you the floor. I give you the floor.
yeah. And if I can add, I mean, if you later can comment, Ashkan, if do you think we still have a role of factor 10, 11A inhibition in patients with AF and high risk of bleeding, like patients with amyloid
Yeah.
angiopathy? So might we be thinking about those patients, I mean, as a new treatment group to be evaluated?
So our messaging to investigators when the Oceanic AF trial results came out and were disappointing were always that, one, we always had signals of efficacy in phase 2. The AF studies did not.
Yeah.
Two, we're going against placebo on top of background antiplatelet therapy. Whereas in Oceanic AF, you're going against a very effective comparator, which is apixaban. And three, and this was one of the most intriguing things for me, was that when you look at John's COMPASS trial, which I have to say cannot be understated how important the COMPASS results and dual pathway inhibition were to the development of the second stroke prevention studies, and combining a factor 11 with antiplatelet. That really found the basis of that rationale. Now we had safer drugs to test it, and this is how all these trials came about. But in that study, the dose that was effective when combined with aspirin was rivaroxaban 2.5 milligrams BID, right? So a non-potent anticoagulant dose. We can all agree that if there was a trial of rivaroxaban 2.5 milligrams twice daily versus apixaban in AFib, that trial would be stopped due to the inferiority of rivaroxaban 2.5 BID. And I make that case because the COMPASS shows that the degree of anticoagulation or the potency of anticoagulation required to have benefit for secondary stroke prevention or stroke prevention, when in a dual pathway setting, when combined with antiplatelet therapy, is not the same that you need to prevent stroke in the context of AFib. So you get this synergistic or additive benefit when combining it with antiplatelet therapy. Now, what does this mean for the future of AFib? I think John alluded to this earlier, and you've asked an important question, Gisele, that I think there's still a role of testing these drugs against a non-active comparator in patients who can't tolerate anticoagulation. You could even think, based on the contact pathway inhibition, you could even combine it with left atrial appendage occlusion and maybe even reduce device thrombosis in that setting. So there's a lot of potential avenues to test this in AFib. And we do have those 200 patients who entered the study and were subsequently found to have AFib. So we will have at least some numerical suggestions in a small subgroup. So take it with a grain of salt, but we'll be presenting those as well in ISC and hopefully have some indication of whether this could be a promising route or not.
Excellent. Really, I think we are all excited to see the final results in New Orleans in February. So Mike will have a lot of us sitting there in the first row and listening to the results. So with this, I thank all the speakers because it was really great. Thank you, Gisele. Thank you, John. Thank you, Ashkan. And I pass the floor to Laura to give some of housekeeping notes.
Thank you very much, Valeria. Thank you, everyone, for being here, for contributing to this webinar. Before we close, I wanted to draw your attention to the QR code on this slide, because this will take you to the dedicated resource page where you can already find related materials, including the Meet the Trialist interviews, which we recorded at the World Stroke Congress in Barcelona, and also a previous webinar on antithrombotic therapy for atherosclerotic stroke prevention. This is also where we will be uploading the infographic with today's key takeaways, as well as the recording of this webinar. So please do check it again in the coming days. And once again, we thank Bayer for supporting these educational activities with an unrestricted educational grant. I want to thank our audience for the continuous engagement they've shown and given to the World Stroke Academy. This was our last webinar of the year, and it has been a pleasure to close the year with you with such an excellent panel. We look forward to welcoming you again in the new year with more stroke education, so stay tuned for that. And until then, take care. Thank you, everyone.
Thanks. Bye-bye.